So what I'd like to talk about is something that rather surprised. I mean, you may not be surprised about this, but I was surprised about this, that this was such a big deal. So my background is philosophy and pretty much strictly medical ethics, applied ethics. And when I was got the position of BRC Ethics Fellow about 3 years ago, I was told that one of the things that they wanted me to work on was patient and public involvement. And I said, that sounds fine. Where's the ethics? So one of the things that struck me after this is that I didn't quite see how ethics fit in here until I started to understand a bit about what was involved in patient and public, what patient and public involvement involved. And the tension, this is what I wanted to, where I got to this sort of set of arguments, is that on the one hand, there's a really strong movement in the UK and indeed internationally towards, for want of a better word, community involvement. You have to talk to the people. And, you know, we could tell a story about how this happened in the UK, you know, Tony Blair's focus groups, now we've got the big society. I mean, there's lots of different sorts of stories and accounts that we can give of why this is such a big deal. But now it's a big deal. Now it matters. There are all sorts of institutions across the UK and across the world that are about raising questions to researchers about the involvement that the public, that the community have in research. I mean, some of the things that are quite interesting, I think. So one really good example, I think, of where this has sort of come out of is research in the developing world. It's research in Africa. There's a lot of research on HIV, AIDS treatments that really went in to develop these vaccines or to develop particular sorts of treatments. And really there's very little concern about the way in which the community involved here. The famous one was AZT, which was way too expensive a drug for any of these African communities to use, and yet it was trialled there. So lots of different, that's one example. The other example is, it's a sort of really useful one, I think, in the European context, is new technologies. So things like stem cell research, that was a big one in the US, things like cloning, IVF technologies, other reproductive technologies, all of these things where scientists are sort of, as it were, pushing out the boat, and all of a sudden the public think, well, hang on a sec, or various representative groups of the public, or groups within the public say, hang on a sec, we want a say in this. I mean, whatever our final account of why this has become such a big issue, it is a big issue. And we have all sorts of groups and organisations that are devoted to just thinking about getting researchers to get the public involved. On the other hand, not that we ever want to use this phrase, the poor scientist, we have our medical researchers who just want to get on with their research. And they think, look, you know, so if I'm studying the way in which cell walls function, the way in which viruses breach cell walls, why should the public be involved in that? Where does the public fit in those sorts of discussions? And how am I going to begin? You know, it's quite terrifying for a lot of scientists. So this is the sort of world that I come into, and I think, well, hang on a second, where does this get? So the question that I've tried to begin to address is the question, why should we involve in the first place? So all these things have evolved patterns of involvement and ways of engaging with people, getting the public to involve, without really a lot of reflection, surprisingly little reflection on why we should do it. Now, if we have a clearer answer to why we should involve the patients and the public, then that presumably will inform both the tension between these groups and also the systems for the way in which we go about involving them. So that's what I wanted to talk about today in the next little bit. I'll start with a quote, and I need to be a little bit careful about how I quote Sally Davies, as she's the head of the NIHR, which has decided that the Oxford BRC should actually get the funding that it's got. And so she really has paid my wage. So I need to be a bit nice. But she says this is a while ago now. No matter how complicated the researcher, how brilliant the researcher, patients and public always offer unique, invaluable insights. Their advice when designing, implementing and evaluating research invariably makes studies more effective, more credible and often more cost effective. I'll come back to this a few times. I want to pick it a bit. So you'll see I'll pick out little bits of this as we go along to think about how we might reflect on these sorts of claims. So first point about just what I'm talking about. I'm talking about patient and public involvement. There's a range of different ways, concepts that we can use for thinking about the way in which the researcher interacts with the public. There's of course also questions about who the public is. Really interesting questions about that, but I won't talk about them right now today. But here's just a quick range of different kinds of things, and basically you can sort of start up here and move down. I think on the Involve website they have something very much like this, where this is sort of trivial, this is the sort of doesn't really count that much as involvement, consultation's a bit better, engagement's a bit better, but these are the ones that really matter. The ones where you get the public deciding what research take place, they're the things that really count. There's a lot to be said about that, but there's a sort of range of different things that we might catch under the term involvement. And there's a lot to be said about that. Sorts of strategies that we might use. This is more at the bottom end, so we're talking about the bottom end of involvement where the public actually has a say in the kinds of things. These are the sorts of things that we might use. Have committee member, lay advisory groups, various sorts of other ways of getting public input and this of course fits through that range of participation, consultation and engagement. And indeed, again, from the Involve website we have this cycle, and they go through saying at each point of the research process we can think about the way in which the public should be involved. So there's a huge range of different things. So evaluating the research or managing the research or designing the research, you might get some input about sort of patient information sheets, or what are the sorts of things that are effective, what do the particular patients need or want. And then at the point about commissioning, you might think having some patient or public input on which piece of research gets involved. These are the sorts of things that are at issue. I haven't said anything about what's preferred yet, but these are the range of things that we're talking about. Okay, so confronted with all of these things, I want to go back to the poor researcher, so-called. There's the skeptical view. And I've come across quite a few researchers who, again, rightly or wrongly, take this sort of view. Spend all your life training, and now we've got to think about all this sort of stuff about how we get the patients and the public involved. So, getting a sense of what the skeptical view might be, we might say, look, patient and public involvement is costly, makes it more bureaucratic, more forms to fill out. We've got to have, think in different ways about what's understandable. I mean, how do we capture, for example, the background discipline in which this piece of research fits, if we're going to start to involve the public in this more often? The second point is the one that I think is the hardest to handle in certain respects, in that, these people have spent a long time becoming experts. And there's a certain sense that, and I think there's some legitimacy to this, that this is really undermining the sense of expertise. I think there's a lot very generally to say in society about the way in which we now think of expertise, and the way in which these sorts of movements about devolving responsibility really undermines how we think about expertise. And I think there's an interesting trade-off in here, an interesting set of issues to be thought about. This idea about the popularity contest, that if it's just about, that we can imagine whoever's got the sort of catchiest acronym, or picks out something particularly appealing, or has a nice picture or something like that. These are the sort of things that you might worry about, at least the skeptic might be worried about. And then the other part of the skeptical view is this idea of a general contemporary political rhetoric that we might also be worried about. So this is the sort of position that a skeptical view, person who's skeptical about patient and public involvement might take. I guess this strategy, if it's not already clear, the strategy here in answering the question, why should we do PPI, is, and this is, I guess, it's an old philosophical strategy. So first you start off by saying what's wrong with it, why you wouldn't do it, and then you try to respond to that and build up an answer that gives you a positive account, which is what I want to try to do. But we need to be a bit more generous to the skeptic here, I think. Skeptic can come up with all that sort of stuff, but they might have a sort of more nuanced position. So they might make a few concessions. They might say, look, okay, I'm being a bit silly here. I can see how patient and public involvement, as it were, at the patient end of research is really important. Right? So you don't want to conduct a whole amount of research on something that doesn't make a difference to patients. Right? If, for whatever the condition is, if the patients really care about pain for this particular condition, but they don't care about the fact that they have dry mouth, there's no point studying dry mouth. Right? So that's the point, is at this end of the translation process, you might think that's the point at which patients and the public can make a clear difference. Right? But it makes less sense at the other end. So a skeptic might say, well, look at this, at the sort of, perhaps the health services end or at the sort of patient delivery end. We're making widgets or actually dealing with them, that's the stuff. But with the sort of basic science end, more towards that end, it makes it a bit more of a struggle. So, what are we going to say to our skeptic? Go back to Sally Davis's quote. This is the point that the skeptic's going to pick up on, right? The public always offer a unique insight, and they invariably make these studies more effective. We might think, well, always? That's the sort of worry the skeptic has. So how are we going to respond to these sorts of worries? Why is it anybody's business? That's the question. Why is the research that goes on inside the hospital, inside the university, on medical research, why is it anybody else's business? Why is it the public's business in particular? That's the question. And you might think, well, that's easy. Oh, let me see. The point about this question is that I think fundamentally it's a really interesting question about the relationship between science and society. So what's the relationship between the scientific research, the conduct of science within a society and the broader society? How are we to understand that relationship? And particularly here, how are we to understand the relationship between medical research and society? Of course, the idea is if we have an answer to this, we'll have a couple of things. We'll have a response to the skeptic, we'll have a justification for patient and public involvement, and we will, I think, have something to say about the intuition that society does actually have some role in this. Right? So this is a kind of handy question. We get all those things out of just answering one question. Of course, the focus here is going to be the second one in justifying patient and public involvement, but I think it's important not to separate them out. Right, answers to the question. I'm going to consider a few here. They're all general answers. And then finally, I'll say a little bit about what follows about patient and public involvement. Very broadly, there's an ownership argument, who pays, accountability. Then there's an outcomes-based argument. The reason you have patient-public involvement is because it makes the research better. And then finally, I'll talk about my preferred view, which is this idea of flourishing. But we'll come to that in just a minute. So, starting with ownership. How does this argument go? Remember what we're doing? The answer is an answer to the question of why is it anybody's business? Why is it the society's business what research gets done? And first answer is, well, society owns the research. Society, so the public pays for it. Puts the resources in, enabling the research to take place, and so is entitled to have a say about the direction that it takes. Sort of relatedly, I think we have some claims about accountability. And I put this sort of slightly as a side. So you might say, look, research, because of the payment, the researcher is accountable to society. Right, but before we get too excited about accountability, lots of different ways of being accountable. And it's not entirely clear that just requiring accountability actually implies patient and public involvement. Right, so one way of being accountable is having an audit at the end, right? Or having some public committee, which has the sort of, as it were, includes the great and the good on it, and that their findings are published, are made public. So you might say accountability is important, but it doesn't necessarily follow that if we require accountability, that therefore you should do patient and public involvement. So we're on this idea of ownership. Society pays, but society doesn't always pay. What do we do about money for research funded by the Wellcome Trust or by private donation? When it does pay, it might pay for a whole system of research rather than for individual bits of research. So our scientist who's working on cells, understanding cell mechanisms, might be part of a big organisation. And at some point, with some research, there should be some involvement, maybe, on this argument, but not necessarily all of it, right? What the researcher might care about is that the research gets done. But I think most importantly, even where it doesn't pay, we still think there's a connection. We still think there's a relationship between research and society. The best example here, or an example here, is the debate that happened in the US about stem cell research. So you remember the Bush government said, the Bush administration said, we're not going to fund for any stem cell research, with some qualifications, on government money, but didn't outlaw any other. And there was still outrage. The debates about whether or not you should do stem cell research and the role that people had, took themselves to have in that research, in those claims, were claims that weren't related to this paying business. So I think my view about this, I think, is that there's something more than just the payment ownership point. It can't be just the ownership point. Of course, it is important to remember that I'm looking for a general justification. So it's not going to be a good enough answer if we get a justification that just allows for some PPI. Right? What we want is a sort of systematic defence, if there is one to come up with. Right, so we might modify this outcomes view a bit. We might say, well, it's not actually the fact that society pays that's a problem that's driving this. It's that it's related to what medical research is for. Think about why we conduct medical research. We come up with a couple of different things. To make current and future people better off in health terms, to improve welfare, quality of life, to avoid harm, provide benefits to patients. All of these things, we might say, look, these are all about outcomes. I guess my question about this is, why does any of this require PPI? That is, why does involving patients in the public help avoid harm or make people better off? Presumably that's the quality of the research. The research works well. The other thing about it is how we would measure that it was actually making the research better. That is, making the outcomes for patients. This is quite, I have to say, this is quite controversial. I've just had an email today about PPI where people want me to tell them what the outcomes are. How does your research, how does your patient and public involvement make the NHS better for patients? You know what? I'm not sure it does, necessarily. I can see some research that will. So this patient end research will make it better, I think. We have a problem about measuring this, right? So we get the patients involved in this piece of research and the piece of research is really useful. But how do we tell that it was the patient and public involvement that made it better and not that it was just a really good bit of research? There are ways around that, but it's an initial sort of problem. I think if we do think it helps, as I've said, I think it selectively helps. It helps in places. So again, we don't get a general justification for patient and public involvement. What we get is patient and public involvement is justified where we think it's likely to be beneficial for the research. And so our cell scientist is, as it were, off the hook. We might be happy with that. I'm not quite ready to get there just yet. But I think this is an important point, this point about health outcomes, because a lot of the sort of metrics that we deal with at the moment in the NHS are driven by outcomes. come back to that in just a minute. One final attempt at the outcomes account. We might say, look, it's society's business here. Society's responsible for welfare here. So, the state has an obligation both to protect the members of society and promote their welfare, and so should supervise research to ensure benefit and avoidance of harm. It's almost like a combination between the sort of ownership point and the outcomes point. Patient and public involvement helps the state, on this view, to regulate research. That should strike you as kind of odd. It certainly strikes me as kind of odd. Of course, this is sort of one of those sort of neat little tricks. Overall harms and benefits might align with less PPI than more. So it might be, if we looked at the overall harms and benefits of a research system, that overall we're better off not having any patient and public involvement than having some. It's hard to know how we'd quite measure that, but at least it's a possibility. Okay, back to Sally Davis's quote. The one thing we haven't touched on, and the one thing I want to come back to now, is this idea of credible. I mean, I take it that the rest of it I've kind of been attacking. This is the bit that's left, right? So I may say, no matter how complicated, it makes it more credible. And that's actually what I want to suggest. And it goes back to this point about looking for outcomes. So I want to explore why we think it's important to involve the public, not because it makes the research better, but because we ought to. It gives us some sort of legitimacy. If the public are involved and are involved in this sort of stuff, there's some value in that which is over and above an outcome. It's a moral, it's an ethical value. There's an ethical value to doing this, which is separable from the benefits that necessarily accrue. So this is where I turn to this third idea. This idea of research, the flourishing idea. This has its sort of philosophical roots in Aristotle, in case you're interested. And the idea here is to not talk about research for just a minute, but to think about inquiry. And you think about, well, if you thought about a life, a human life, that went well, where you could say of that person that they were flourishing, in a way that they're leading their life in the right kind of way, I would suggest that that's a life that involves inquiry. Understanding the world around them, understanding people, knowing people, being inquisitive about people, this is important, seems to me. We think about leading a flourishing life, we think about a life that has inquiry as an important constituent of it. So now how does research and inquiry fit together? Well, you can imagine, as you have a more sophisticated society, that you now have institutions of inquiry. And what's an institution of inquiry? Well, a university is an institution of inquiry, and as well as teaching. You have research institutions are institutions of inquiry. So the idea is that the research and the research that we conduct on this large scale in our society is an institutionalised form of inquiry. That's the way in which our society is developed and the institutions are developed up around it. So the idea is the value of research, why we should conduct research, ties back to why we should inquire. Because it's something that's valuable, it's a valuable part of human life. So, what this means, I think, is that inquiry and the value of inquiry, and so the value of research, is tied to this idea of research being a social enterprise. It's something that we conduct as a society. Its value comes from the value to human lives, to human flourishing, and so similarly research becomes this idea of this social enterprise. Again, coming from this idea of inquiry being part of human flourishing and so research being important, I think it's important, what follows from that, is that research is participatory. Inquiry is something that we should engage in, and so research is something that we should engage in. And this is the idea of it being a participatory event rather than something that somebody goes off and does without us really bothering about it. Again, all of this flows from this idea as research being constitutive of human flourishing. What this means is the value of involvement lies in the engaging by the public with the research and the provision of opportunities to engage by the researcher. There's a certain way in which this value now, it's the value to the public of the involvement rather than the other way around. I think when we talk about outcomes too much, we think about the outcome to the researcher or to the research. But I think the value of patient and public involvement actually lies with the people who are involved, the public who are involved. And so this relation, the idea of engaging, of participating in the research is something that's worthwhile. That's the thought. So, that's the picture. There's more to say about it, but I'm sure you'll ask me about it in just a minute. One of the things you might think, after having heard all that, is you might say, well, hang on, there's a couple of things he hasn't mentioned here that we really need to touch on. And that's what I mean here by 3 further justifications. 3 things that you might think, well, hang on a second. So the first one's representation. So you might say, well, why haven't I mentioned representation? This idea, what PPI does is allow representation in research. I think if we think a bit more about representation, it's either about ownership, you should be represented because somehow you own it, or you should be represented, public should be represented here because somehow that's a way of providing benefit. So I think this representation model ends up being one of either ownership or benefit, which we have dealt with. I mean, the thing to compare this with, I think, is the resource allocation, priority setting stuff. I mean, there it seems very much an ownership point. So representation is important on priority setting committees because there is an ownership question here. What about empowerment? It's one of those buzzwords. Patient and public involvement empowers patients and the public. Fantastic. Why empower? Why do the public need to be empowered in this? So we get back to the original question, right? Presumably, they only need to be empowered if it's their business and they don't have a say. So we need an answer to why it's their business. So we need an answer to that earlier question. So I think empowerment, although it's a catchphrase, doesn't actually have much to it in the end. Finally, education. Patient and public involvement helps to educate the patients and the public. Indeed, the Wanless report says that education makes people healthier and healthcare cheaper. It's a good idea. I mean, I'm much softer on this idea about the education. If we think one reason for being a bit hesitant about this is that it looks like the point of this exercise on this story is more benefit. So the outcome is that the public get educated. It's not quite clear that the way to educate people is by involving them in these decisions. You might put on free classes or something. But in any case, of course, education is an important part of the flourishing point. Inquiry is built in. This is part of the thing. You train children to be inquisitive, to understand inquiry and ways of inquiry. So it's really important, I think, that the education bit is part of this. I think it build into the flourishing account. But it doesn't build it in as an outcome. Education's not an outcome. You don't educate people because they then go on to be happier or better or healthier or whatever. You educate them because inquiry is of value. And that's one of the things that you want to instill in them. Okay. What follows about patient and public involvement? I said I'd come back to worthwhile. I'll come back to that in the next slide. Of this argument, what can we say about why we should do PPI? I've suggested that the third option gives us the best account of the stake society has in research, the best account of this relationship. So we ought to do patient and public involvement because research is a social enterprise. It gives us some obligation to conduct patient and public involvement, but not an overriding one. It's not the be-all and end-all on this view. Indeed, on the kind of account I've been trying to give, PPI is better thought of as a curiosity. It's about curiosity. It's about enlivening people's curiosity and interest, not about oversight. It's not something that you force down people's throats, either the public or the researchers. But what I haven't done in all of this is I haven't ruled out any of those other considerations, right? I haven't said anything about the ownership point or the welfare point. So those are still relevant considerations. They're just not overall accounts of why it matters. Some kinds of cases they will matter. So the idea here is to go reflect on this over what makes particular bits of research or what makes research generally worthwhile. Now I've used worthwhile rather than beneficial or good or any of these things, because they're all outcome measures. Worthwhile is not an outcome measure. We do things that are worthwhile irrespective of whether or not they make us happier or better or healthier, etc. So it's supposed to capture all of the things that we've been talking about. Some things are worthwhile because they make us better off. Some things are worthwhile for other reasons. So here, research is worthwhile when it contributes to human social flourishing. So a piece of research might not make people's lives better in the end. I mean, you might want medical research to aim at that at least, but you might think other sorts of research might not be aimed at making people, it might be aimed at understanding the world in a particular way, which may have benefits or not, may not. But what it certainly doesn't rule out this idea of worthwhile. It doesn't rule out this idea that the research is internally justifiable. That it's good for doing, it's good to do this research because it's a good piece of research. And it doesn't rule out it being more useful or less useful, and so more cost effective in the way that I'm sort of reinstating some of the things that Sally Davis has said, I think, which is all nice. So, the researcher's worst fear was all PPI all the time. I think we have an account of, we can ease their fears about this, I think, on this account. It's not about all PPI all the time. From what I've suggested, patient-public involvement's a consideration rather than a moral requirement. When and how much is something that we need that in the BRC we need to think some more about, and which I'll be working on in the coming years, is we need to have a picture of how, when and how much. It's going to depend on the research, but most importantly the idea is it depends on being open and allowing the research to be open to patients in the public who are interested. And that, I think, this last slide and the first bullet point and the last bullet point are sort of what I think the argument takes us to. This is not something that should be oppressive, and this is one of those things that takes a lot of work, right? Not something that should be oppressive, it's something that should be open and encouraged, and the value of it realised without it necessarily being an overwhelming bureaucratic institutionalised activity. Thank you.